Okay, now it's recording. Perfect. So, can you guys just tell me the lateral plate mesoderm is going to give rise to certain things within your entire nervous system. So I want you guys to be telling me that. Okay, we had discussed each and everything in a big detail. Yes, lateral plate mesoderm. Yes, guys, just wake up, please. Turn on your mics.
Muscles connected
Okay,
tissue,
perfect. Perfect, mesentery. And we are aware of the fact that basically the mesentery is going to give the blood supply to your entire tract, right? So all of the blood supply of your entire tract that we are going to discuss in our future slides, basically it runs within the mesentery, which is an important structure, right? And we discussed that at 6 week of your development, what happened? The midgut is going to herniate outward via umbilical ring. Why? Because inside your gut, you don't have enough space for the midgut to grow. So what happens? The nature give us a mechanism. It would just herniate out. It would just get matured out of your abdomen, by the way. And what happens is it herniate out. So after some time, that is at week 10, it would just come back into your abdomen. And then we are going to have an important, step, or you can just remember. That is 270-degree anti-clockwise or counterclockwise rotation. Once it's just rotated, then it's going to get its place where it's supposed to be there. Okay, so at the 6th week of at 6 week it's going to herniate. The midgut is going to herniate outward. And what happens at the 8th week, we discussed, you are also going to have an important step, that is gut lumen is going to recanalize, right? You all guys are already aware of the concept that normally the hollow tubes once used to be a solid tube, right? Then a process of recanalization, that is making of the canals or the space, the empty spaces or the lumen, is basically made by a process which is known as canalization. Okay, so at the 8th week, basically we are going to have a canalization process. And at 10th week, as we discussed, all of this herniated midgut is going to return back into its abdomen, and then it's going to have 270-degree counterclockwise rotation. Once it's rotated properly, then it's going to get its normal location, which now we exist. Okay, that's simple. So the gut section, we discussed that we have different gut section, right? Foregut, midgut, and hindgut. So you guys are going to be telling me the foregut arises from which part, ends at which part, what's the blood supply, and same about midgut as well as hindgut. Yeah, so anyone who can just please tell us, I'll be writing it.
Yes, the foregut. Can you hear me?
Okay. Yes, we can hear you. Foregut.
From esophagus to the upper part of the duodenum, exactly till the ampulla of Vetter.
Okay, ampulla of Vetter, like I would say some part of duodenum, right?
Yes.
Ampulla of Vetter. Okay, it's gonna be your foregut.
Yes.
Okay, and what's the blood supply of your foregut?
Celiac trunk.
Okay, perfect. Celiac trunk. Okay. So for the foregut, okay, what are the structures which basically we consider to be a derivative of your foregut? Yes.
Esophagus, stomach, spleen, and the upper part of the duodenum.
Okay, pancreas, stomach, gallbladder, liver, and trachea as well, right? As we discussed that foregut, from the foregut in the respiratory section, we discussed it's going to have an outgrowth which is known as respiratory diverticulum, and while certain intermediate steps, it's going to be converted into your mature lung by aspirating your amniotic fluid and things which we discussed in detail, right? In our respiratory section. So let's discuss something about midgut. So can anyone just tell me the midgut, it starts from which portion and at which portion? Midgut.
From lower duodenum to the proximal part.
Okay, perfect. From the distal duodenum till your
2/3 of the transverse colon.
Perfect. 2/3 of transverse colon. What's the blood supply?
Superior mesenteric artery.
It would be
SMA.
superior mesenteric artery. Perfect. Okay. Yes. Can anyone just tell me about hindgut? Anyone else? Please, guys, just participate. I want you guys to be participating. Yes, Dr. Abdul. Can you just please tell us?
Distal 1/3 of the transverse colon till the anal canal.
Okay, distal 1/3 till your anal canal till the pectinate line. Okay. And what's going to be its blood supply?
The inferior mesenteric artery.
Inferior mesenteric artery. Perfect. That's perfect. Okay. So these were some of the gut section which you guys should know. Okay. So let's discuss some of the pathologies associated with it. So I would be asking you guys some question, you guys have to raise your hands, those who want to answer, and then we'll be moving forward. Okay. So can anyone just tell me about, okay, we have folds, right? That is, we have lateral folds, caudal folds, and rostral folds. We already discussed it in detail, right? Lateral folds. Let's discuss some of the pathologies of lateral fold. For example, if the lateral fold failed to close, we are going to have two pathologies. Can anyone just name them? Only name them, okay? Yes, Abdul.
Gastrocesis.
Gastroschisis and
I just know that.
Omphalocele.
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 Perfect. Gastroschisis and omphalocele. For example, if the caudal fold fails to close, then we are going to have a pathology. You can say, what's the name of that? Yes, Victor.
Bladder,
Umbilical hernia.
Bladder.
Okay.
bladder exostrophy.
Yes, bladder extrophy, right? Bladder extrophy. For the umbilical hernia, we are going to discuss that is due to failure of the umbilical ring, by the way. Okay. Okay, perfect. Okay, for the rostral fold, for example, if it failed to close, then again we are going to have a pathology. So Dr. Victor is again going to tell us what's the name of that.
Cardiac ectopy, cardiac or
Okay.
cardiactopy, something like that. Yeah.
Perfect. Ectopia cordis. Okay, in that case, like in the bladder extrophy, basically the bladder is gonna, you can just visibly see it, right? And in case of ectopia cordis, the heart is gonna be present outside. You can simply see heart beating and pumping blood, and the skin would be just moving. You can simply seeing the picture, you can simply know that it's ectopia cordis. Okay, so let's discuss the pathologies of lateral fold in a little bit more detail, right? So the first one which we'll be discussing is omphalocele. So Dr. Daniela is going to tell us, yes, what is omphalocele?
Omphalocele is kind of like the herniation of what's it called? The abdominal contents through the
Oh.
umbilicus. The,
Okay.
Yes.
Perfect. Can I say that it's a persistent herniation?
Yes, it's persistent.
Like there
It
is
does
a
not.
difference between herniation and persistent herniation. But the term persistent
Yes.
herniation means that normally, as we discussed, it's going to herniate outward, right? But not for the normal individual, this herniated content of your midgut should go back, and it should, counterclockwise. It should have 270-degree or rotation. Then it's going to attain its normal position. But if the herniation persists, then we are going to have omphalocele. Is that clear? It's a persistent herniation. Perfect, right? So, can you just tell me what will happen to the level of AFP in case of omphalocele?
It's decreased.
Is it decreased? Is it
Sorry,
normal?
alpha fetoprotein. Sorry.
Yes. Would it be increased, normal, or decreased?
Normal.
I thought in omphalocele is decreased, then in gastroschisis is increased. That's how.
Mhm, okay.
I'm not sure.
Okay. Okay. Anyone else?
Is it normal?
Okay. Anyone else? Yes, guys. It's a kind of discussion. Please just participate. What do you guys think?
Alpha fetoprotein decreased only in Down syndrome, and in omphalocele it will be increased. It increased in all the other syndromes, only decreased in the Down.
Okay, only decrease in down. Okay, so if you just, okay, there is a concept you guys should know that. Okay, so normally those who are having omphalocele, those babies or individuals who are gonna be having omphalocele, basically they have some pathologies associated with that as well. That is trisomy 18, Patau syndrome 13. We know that, and Beckwith-Wiedemann, right? In those pathologies, basically what happens to the level of AFP, it's gonna be decreased. If you're only talking about omphalocele, it's going to be increased. But like if an individual is having already Patau syndrome, if he's having trisomy 18, so due to that, the AFP should be decreased. Okay, the AFP should be decreased, and if again he's having omphalocele along with that, so it means the AFP should be increased. So at one aspect we are seeing decrease, and on the other aspect we are seeing increase. So normally you are going to see normal level of AFP. Is that clear?
Yes. Okay.
So it's normal.
Okay.
So
Yes,
it's
gonna
normal.
be mostly normal.
Mhm.
Yes, it's mostly going to be normal. If you have like Patau syndrome associated with omphalocele, which is most commonly going to appear in your exam. Okay, so normally it's going to be normal. So for step one, you should just keep that in mind. While in case of gastroschisis, so Dr. Ahmad is going to tell us what is gastroschisis and how to differentiate it from omphalocele.
Me, doctor?
Yes, please.
Yes. Gastroschisis is the outward protrusion of the abdominal content without the peritoneum covering.
Perfect, perfect. So in amphilicele, one thing which we missed, we are going to have a proper peritoneal covering, right? But in case of
Yes.
gastroschisis, we won't be having a peritoneal covering. That is, it would be tearing the abdominal wall, and all of the contents are going to move outward. So can you just tell me, like, as with comparison of your umbilicus, would it be present at the right side or left side, the schisis?
It's on the left side.
Anyone
Right.
else?
On the right side.
Right side.
On the,
Right
it's on the
side.
right.
Right
It's on the
It's
right.
right side. Okay.
Perfect, right side. Okay, raise your hands, but I still need that kind of enthusiasm, right? Before answering, please raise your hand, but the enthusiasm should just remain constant. Okay, perfect. So what would happen that in gastroschisis, basically it's a tear, right? So what happens that all of the abdominal contents, like at the right side of your umbilicus, they are going to come outward. They won't be having peritoneal covering. It means it's an emergency condition. Why? Because if we do not have peritoneal covering, there is increased chances of dehydration, right? So one of the
Yes.
management should be that you should first of all put a gauze there in order to avoid dehydration, and like you should just do some kind of surgery in order to, like, deal this condition as soon as possible, because it's an emergency, right? That's more of step 2, and we're just talking about step 1 here, right? So what will happen to the level of AFP? That's an important thing which you guys should just keep in
Yeah,
mind.
it will increase, doctor.
Okay, perfect. It will increase. So simply you can think of, if amphilicele is having a proper peritoneal covering, it means that the alpha fetoprotein cannot move outward. That's the way you can just keep in mind, okay? So the AFP is going to be normal, right? Simply you can think, if it's having a covering in case of amphilicele, AFP would be normal, which is an alpha fetoprotein, protein associated with your fetus. Simple. Let's make it simple. But in case of gastroschisis, if you do not have a proper peritoneal covering, what happens? AFP is going to raise. Is that clear?
Yes, sir.
Yes, doc.
Perfect. So you're going to have a lot of MCQs on, and you guys might have practiced that, and all of the concepts revolve around these things which we discussed. Okay. What else? We have another condition that is known as umbilical hernia, right? As Dr. Judith discussed, right? So what happens in umbilical hernia? Can anyone just differentiate both of these 3 conditions if we are just visually looking towards them? Dr. Daniela, yes, please.
Yes, the most difference is with congenital umbilical hernia is covered by skin.
Okay, perfect. It's covered by skin. For amphilicele, it's going to be covered by your peritoneum. Or in case of gastroschisis, you have nothing to
No covering.
No covering. Okay, but in case of umbilical hernia, we are going to have a proper. Yes, it's reducible. You can just put it back by your fingers. Simply, you have a UWorld video. If you guys have a video kind of, and UWorld, they have just explained it quite great, right? So what happens? It's reducible. It can go back into the. If you just push it, you can just get it back into the abdomen. Okay, perfect. And what's the main pathology behind it? Very important. One of your UWorld MCQ: failure of umbilical ring to close. Failure of umbilical ring to close. Another important point which you guys must keep in mind: there are 2 conditions associated with umbilical hernia. If someone is having which 2 conditions, they are more prone to have umbilical hernia. So Dr. Shafiq is going to tell us that. Yes, Dr. Shafiq. Yes,
You
Dr.
mean
Mariam.
Yes, it's
yes.
the Down syndrome and the
And
congenital
hypothyroidism.
hypothyroidism.
Congenital
Perfect.
hypothyroidism.
Down syndrome, hypothyroidism. Keep that in mind. Very high yield. You have a UWorld MCQ in endocrinology section with same, presentation with umbilical hernia associated with hypothyroidism that we discussed in a big detail. Okay, perfect. So let's have our discussion on another important pathology, right? So again, I'll be asking you guys, because we discussed it in a big detail. We discussed it in our respiratory section as well as in our okay, that is tracheoesophageal defect, right? So I want you guys to be telling me the 3 variants of TE defects, tracheoesophageal defect, and along with that, who is going to be telling me the most common variant of those among those 3? Dr. Huda, yes. Dr. Huda, can you please turn on your mic? Can you just please tell us 3 variants of TE defects?
The 3 variants, the most common would be esophageal atresia with distal tracheoesophageal fistula. And then other than that, we have the pure esophageal atresia and the H type, which is the pure tracheoesophageal fistula.
H type, perfect. So let's discuss the most common variant first of all, okay? So as the name indicates that we are going to have esophageal atresia. What do we mean by atresia? Dr. Raj is going to be telling us that. Dr. Raj, can you just please turn on your mic? Please tell us what do we mean by the term atresia?
It means that the tissues, it will end it as a blind pouch, or like the tissues are not formed at that part.
Okay, perfect. So we are
It
going to
has
have a
become
blind.
atretic.
Yes, it's atratic, or it's like a blind
Yeah.
tube, right? Having no
Yes.
endings in it, right? So as the name indicates that esophageal atresia with distal tracheoesophageal fistula. So everything is clear. What would be the presentation? That's clear. If the esophagus is atratic, it means that the normal process of swallowing of your amniotic fluid isn't going to be well. It's going to give rise to a condition that is polyhydramnios. You guys know that, right? If
Yes.
fetus cannot swallow amniotic fluid due to atratic esophagus, so he's going to end in what polyhydramnios, right?
Polyhydramnios.
What else?
Yeah.
He's going to be having drooling of saliva, right? It would be another presentation. Why? Because all of the contents. Okay, can we just pass NG tube? One of the diagnostic feature of that.
No.
No. Perfect. He's going to have choking. That is, things can just move into the into the trachea, right? Okay, perfect.
Yes.
What else we are going to see? We can, like looking towards the distal aspect, that is distal tracheoesophageal fistula, right? So either the content from the stomach can move into your
Lungs.
Trachea.
lungs,
Trachea.
right? Trachea,
Yeah,
lungs.
lungs.
So, for example, if we have content moving into, so what would be the risk factor for this individual? We're gonna do
Aspiration
Pneumonia.
aspiration pneumonia.
Pneumonia.
Perfect,
Yes.
right? Aspiration pneumonia. And okay, let's discuss some of the respiratory things as well. Which drugs are we gonna see there? Okay, which bugs are we gonna see there if someone is having aspiration pneumonia? One of the
Bacteroides.
MCQ.
Bacteroides,
Yes, perfect. Fusobacterium,
anaerobes,
right?
anaerobes.
Anaerobes.
Streptococcus puridi.
Okay, perfect. Klebsiella. So these are going to be some of the bugs which are normally present within the entire flora. They can move with aspiration. What else? The air can also move into the stomach, which is going to give us, distended stomach. Is that clear?
Yep.
Oh, perfect.
Yes.
So let's discuss the next variant of PE
I'm
defect.
sorry,
That is going to
Dr.
be
Ahmed, can you please repeat what bugs would be present in aspiration pneumonia?
okay. So the idea is really simple. If this is our trachea, okay, this is our esophagus, blind tube, right? And then we have distal esophagus with stomach connected to your trachea, right? So the content of your stomach can get into your trachea, right? And which bugs are we going to see? They're anaerobes, right? Which anaerobes? Klebsiella, bacteroids, fusobacterium, right? So you have a UWorld MCQ on fusobacterium. In the respiratory section, we have an MCQ that are going to ask you that we have a patient with aspiration pneumonia. We found fusobacterium. So what do you think? He's most likely going to be an alcoholic, right? Because in case of alcoholics, they are more prone to aspiration. Is that clear? So this was one of your UWorld MCQ. Is that clear?
Yes, it's clear. Thank you so much.
Yes, Doc.
Perfect. Let's discuss our next variant, that is pure esophageal atresia. Who is going to be telling us pure esophageal atresia? Will we be seeing any gas in stomach? Yes or no, Dr. Mariam?
No.
No.
No, we will see
That's
gasless
no.
stomach in the pure atresia.
No.
Perfect, no gases, right? Okay, so pure esophageal atresia. Then we have an H type, right? So what will be happening in H type? You guys already know that. Who's going to be telling me that?
There will be
Gastric
gas
bubble
in
is seen.
Yes. In the
Yes.
stomach.
Again, we can have gastric bubble. We can have aspiration pneumonia. If we have an H type,
Yes.
the idea is really simple. We have more chances of getting air into your stomach or either getting stomach content into your lungs, right? So there can be both chances of having distended stomach along with aspiration pneumonia. Perfect. So let's discuss our next topic, really important topic, I would say really high yield. That is intestinal atresia, right? So what is intestinal atresia? We discussed that atresia is a kind of, whenever we have a blind tube, right? So how do we get that atresia? We also discussed that. We can have two associations associated with that, okay? So let me draw it here, right? So as we discussed that atresia is basically blind ending tube, right? Blind ending tube. You can get atresia by two mechanisms, two possible outcomes. Either, we know we have a process of canalization, right? right? That is okay.
Yes.
That is like making canals within the solid tubes, which is a normal process, right? And we have blood supply of these entire tubes as well. So, for example, if the canalization failed to occur, if you cannot make those canals via apoptosis, what happens? Like, for example, we discussed that initially all of the tubes existed in a form of solid tube, right? And then a process of canalization occurred in order to make, or like make the proper lumen. So if the canalization fails, it means we cannot make a proper lumen. For example, if it fails in certain area of their tube, for example, in this area. So if we cannot canalize it, it would end in a blind tube. What else? For example, if this area is being supplied, let's suppose by some blood vessels, let's suppose some blood vessels by your from your SMA, right? And for example, if we have stoppage of that blood supply, right? So what happens? This area can undergo ischemia, right? Ischemia, necrosis, and what is necros? By the process of healing, again, it's going to end in a blind tube. Is that clear? So these are two main ideas which you guys should keep in mind. Is that clear?
Yep.
Yes.
Okay. So if someone is having intestinal atresia, for example, duodenal atresia, for the duodenal atresia, we know it's due to failure of recanalization,
Yes.
right? Is that clear? So it's due to failure
Yes.
of recanalization. So you guys are going to be telling me the clinical features, or the presenting features. For example, if someone is having okay, let me just ask you some questions. Okay, so we have an individual with duodenal atresia. First of all, we are going to see double bubble. Why?
Yes.
Why?
Because of dilated stomach and air.
Perfect. If the duodenum become atretic, what happens? For example, if this is your stomach, let's suppose your stomach, okay, and this is your duodenum. For example, if this part become atretic, right? So what happens? All of the content of your food content is going to back up, right? So what happens? You're going to see a bubble just near or close to the proximity of your atretic duodenum and in the stomach as well. So we are going to see two bubbles, right, on imaging.
Yes.
That's known as double bubble. What else is basically associated with Down syndrome? So the mnemonic for that is 3 Ds, right? Duodenal atresia, double bubble, and Down syndrome. That's everything which you guys have to know. What else we have? Jejunal and ileal atresia as well. Jejunal and ileal atresia. And why do we see jejunal and ileal atresia? That's most going to be due to failure of the blood vessels supplying a specific area of your jejunum or ileum, right? In that case, we know that it's going to become ischemic, necros, and atretic, right? So we are going to have a specific appearance on imaging that's basically known as something related with apple.
Apple
Yes.
peel appearance.
Apple peel appearance, right? Apple peel appearance. And the idea is very simple. For example, if this is some part of your jejunum, and let's suppose the small part become like ischemic, so the blood vessels which are basically present here at the distal aspect, it would just become spiral. Okay, the blood. Okay, sorry. So the necrosed area is going to become like spiral against the blood supply, right? So for example, if this is your blood supply, necrosed part of your jejunum or ileum is going to become like that. Okay, and it would resemble an apple peel. That's why we are naming it as apple peel bowel. Is that clear?
Yes.
Perfect.
Yes,
Let's
yes,
discuss
yes.
our next pathology, very high yield, like I would say highest yield among your embryology. That is pyloric stenosis, right? So we already discussed pyloric stenosis in detail. First of all, you guys are going to be telling me which antibiotic intake is associated with pyloric stenosis. Yes.
Erythromycin.
Macrolides, erythromycin.
Macrolides.
Macrolides, perfect, and specifically erythromycin, perfect. Okay, will an individual be having bilious vomiting or non-bilious vomiting?
Non-bilious vomiting.
Non-bilious.
Okay, in case of duodenal atresia, will we be seeing bilious vomiting or non-bilious vomiting?
Bilious.
Bilious.
Vomiting,
Depending on whether it's
perfect.
below or above. Yeah.
Perfect. You have a word answer on that. Okay, mostly in case of pyloric stenosis, in the history, you will be seeing a male boy, right? First born male.
Yes, right.
Yes, first born male. Yes.
Perfect. And we are going to have, okay, for example, if someone is having this vomit, he's going to lose his, he will be hypokalemic, hypochloremic, and metabolic. He'll be in metabolic alkalosis. So you guys are going to be telling me the exact reasons. Wait, please. Why will be he having metabolic alkalosis? Okay, Dr. Daniela is going to be telling us that. Why?
You're vomiting. Vomiting causes alkalosis, right?
Yes.
Because there's yeah.
Simple. We are losing HCl in vomit, right?
Yes. You got
HCl is going a lot.
excessive vomiting. Yeah.
Yes, we are losing acids. It means that bicarbs are going to build up. Simple. Okay. We are going to have hypokalemia. Why?
Because the RAS will be activated. So aldosterone, it will act on this. How is it called? On the proximal cells. Yes. So what it leads to potassium out of and sodium and the water absorb. So because of this, we're
Perfect.
gonna
That's
have
perfect. Perfect. If you're losing volume in vomit, what happens? Extracellular fluid volume decrease. Less delivery of NaCl to macula densa telling your RAS system to be activated. Lot of aldosterone coming from your cortex of your adrenal is going to be acting on your distal tubules. We discuss each and everything in a big detail, right? And it will be telling the K plus to just move K plus, and H plus is going to further move out, while it would just cause the absorption of your Na along with water in order to restore your effective circulatory volume. Is that clear?
Yes.
Perfect, right? Okay, what else? And on presentation, this individual is going to have dash-like mass. Yes,
Olive
fill in the dash.
Olive palpable olive shape.
Olive-like, perfect. And what's going to be the treatment option?
Surgical
pyloromyotomy.
Pyloromyotomy, perfect.
Electrode
Perfect.
replacement, pyrolactomy.
Perfect, perfect. Okay. So let's discuss our next anomaly, that is annular pancreas and pancreas division, right? So we already know, but before discussing that, Dr. Raj is going to be telling us the normal process, how the pancreas had just combined with the other part and things like that. Yes, giving us the uncinate process, combining with the birds, by the way, right? Ventral bird and dorsal bird, everything. Yes, Dr. Raj.
Yes, sir. So, like we have two types of birds, ventral and dorsal. And
Mhm.
in the pancreas, we know that we have a uncinate process, head, body, and tail of the pancreas. So from the ventral bird, this uncinate process develops, and the rest of the pancreas arises from the dorsal bird.
Perfect, perfect.
So
So normally we have two birds, ventral and dorsal. The ventral normally is supposed to, revolve around your duodenum and join with the dorsal bird to give the uncinate process and head. But if we have failure of that, moving of your ventral bird, sometime it can become annular. It can, it can, make a belt kind of again, like around your duodenum, right? And if that belt kind of structure just become like, like more severe, it can compress your duodenum, giving you duodenal atresia. That's basically known as annular pancreas. It will just form an annular structure around your duodenum, right? Is that clear? And it basically happens at 7th and 8th week of development, okay? And it's mostly going to be associated with which syndrome?
Down syndrome.
Down syndrome.
Down, perfect, okay. And we have another pathology, pancreatic division. So Dr. Daniela is going to tell us what is division. Divided pancreas. If I just tell you in simple words, pancreatic division.
Is when the ventral and the dorsal part don't fuse.
Okay, if they do not fuse, it means the anatomy is disrupted. Anatomy of your entire pancreas is disrupted. If the
Yes.
anatomy of your pancreas is disrupted, what do you think in future, which kind of complication this individual could have?
Pancreatitis.
Sorry? Pancreatitis, acute pancreatitis, right?
No
If the
problem.
anatomy is disrupted, there is increased chances of the enzymes being activated within the pancreas. We discuss acute pancreatitis. It will be eating your pancreas, liquefactive necrosis along with fat necrosis of peripancreatic fat. We discussed everything in detail, if you guys remember, right?
Yes.
Hello?
Yes.
Perfect. Okay. So, okay, just give me a second. So with that, our embryology is finished. We'll be discussing anatomy, okay? So just give me 1 minute. Let me just open some slides, okay? Okay. So can you guys just see my slides?
Yes.
Okay, perfect, right? So let's discuss some of the peritoneal structures, right? So we have peritoneum. We know we have our visceral peritoneum and parietal. So this is going to be your parietal peritoneum and your visceral peritoneum, right? So let me just, okay. So this is going to be your parietal, and this is going to be your visceral peritoneum. You guys can see surrounding your viscera, right? So peritoneum in two places, basically it's going to be forming some folds, which is going to give rise to your omentum, right? So we have our greater omentum and lesser omentum. You guys know that, right? So this is going to be your lesser omentum, right? This is your lesser omentum, and this is your greater omentum, which is basically formed by the folds of your visceral peritoneum. Is that clear? Hello?
Yes.
Okay, perfect.
Yes, sir.
So let's discuss some of the retroperitoneal structure. A mnemonic said pucker for that, but we won't be doing that. We'll be starting from the esophagus, going down along your enteric tract, and you guys will be telling me your retroperitoneal structure. It's very important. You have a lot of UWorld MCQ. You guys might have seen that, right? So in the digestive tract, yes, which part of esophagus lies in your retroperitoneal aspect?
The thoracic part.
Okay, the thoracic part. Perfect. So thoracic esophagus. Okay. And what about, oh yes, just move down and just tell me the structures.
Duodenum, second to fourth.
The duodenum.
Duodenum,
Which part?
second, third, and fourth.
We
Okay,
have
what
the
else?
aorta and IVC.
Perfect. Aorta. And
IVC.
what
IVC.
ascending and IVC.
Yes.
Perfect. What else?
We have the
Ureter.
pancreas. We have the pancreas, every part of the pancreas
Apart from
except
the
the
tail.
tail of the pancreas.
Except tail. Perfect. What else?
You have the adrenal gland.
Ureter. Perfect. Adrenals plus kidneys,
Suprarenal
right?
gland. Yes.
Yes. Perfect. So these are the structures which are present in the retroperitoneal aspect. You guys
Suprarenal
must know that.
glands.
Yes. So, okay. We discussed adrenal. Okay. Adrenal gland. Okay. So let's discuss some of the ligaments, right? So ligaments which are attaching different parts. So you guys will be just telling me. I'll be just marking some of the ligaments. Okay. So what's the name of this ligament?
The falciform.
Falciform. Falciform.
Falciform.
Falciform. Perfect. Okay. Okay. What about? Okay. Can you guys just tell me? Okay. What about this part?
Hepatoduodenum.
Duodenum.
Yes.
Okay. Hepato.
Duodenum.
But
Okay.
duodenum.
Okay. So you guys will be just telling me its significance. Let me just give you guys a
The
clue.
portal triad.
Pringle manure. Yes.
Yes.
So we have portal
Right.
triad. Right. So we have a manure that is known as Pringle manure, which we basically perform here, right? Okay. What else? So
Yes.
we have hepatic artery, vein, and common bile duct. Okay. Then we have this ligament. You guys are gonna name it. What's the name of this ligament?
Hepatogastric.
Gastrohepatic. Yeah.
Gastric. Perfect.
Contains the
and-
gastric vessels.
Okay. Okay. Gastric vessels. Perfect. So we're gonna see gastric vessels as we discussed the entire anatomy, the blood supply. You guys already know that. What about this one?
Gastrocolic.
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 Gastrocolic. What are going to be present here?
Gastroepiploic
The
artery.
right, the gastroepiploic arteries, the right one.
Okay, right.
Right gastroepiploic, yes.
Gastroepiploic vessels. Perfect. What about this one?
Gastrosplenic.
Gastrosplenic.
Gastrosplenic. Okay, tail of pancreas plus splenic vessels, right?
Splenic, yes.
Yeah.
Vessels. Perfect. Okay. So let's move to our next topic, that is innervation. So for the innervation we discussed, you guys are going to be telling me that because we discussed in a big detail, right? The parasympathetic and sympathetic innervation of your gut. So for the vagus nerve, okay, let Dr. Muhammad just tell us that. Dr. Muhammad, are you here? Hello? Anyone else? Yes, Dr. Muskan. Can you just please? Okay. Okay. So Dr. Muskan will be just telling us about the nervous supply, the parasympathetic and sympathetic. So for the parasympathetic, we have vagus nerve, plus we have pelvic splanchnic nerve arising from S2 to S4. Yes. So vagus nerve is going to supply, yes, which structures of your yes.
And the forgotten.
Foregut plus midgut.
Midgut.
Perfect. Okay. What about the pelvic splanchnic?
Heinz gut.
Hindgut. Perfect. Okay. For the sympathetic, okay, for the sympathetic, we have, yes, the thoracic, the greater and lesser splanchnic nerve, and the lumbar splanchnic nerve, right? So from
Yeah.
T5 to T12 is going to supply your
Foregut
foregut
and midgut.
plus midgut again. And what about hindgut?
Lumbar L1 to L2.
Okay, perfect. Lumbar splanchnic nerve L1 to L2. Perfect. So it was all about your innervation. Let's discuss a little bit about the blood supply. Okay. So just give me.
No,
Okay,
sorry.
sorry.
No, sorry. I was like, I know blood supply. Sorry.
Okay. Okay. So Dr. Daniel is going to be telling us blood supply, but let's have 2 minutes of break. Okay. I want to take a cup of
T.
coffee. Yeah, so give me some 2 minutes. Okay. Okay. Hello? Hello, can you guys hear me? Hello?
Yes,
Yes, sir.
Ahmed.
Yes.
You can-
Okay, perfect. So, okay, so let's start our discussion further. Let's take it a little further, okay? So, let's discuss our blood supply, right? So, we already know, okay, I'll be just marking the branches you guys are going to be telling me, okay? So, basically, this is going to be your diaphragm, okay?
Doctor,
Diaphragm.
screen.
You can
You
see
need to
your
share the
screen.
Okay, let me just share my screen first, okay? Okay, so tomorrow we are going to start our reproduction session by Dr. Moaz, okay? Dr. Moaz is going to be hosting that session for you guys. Okay. So can you just tell me what's this? Yes, just name it.
The
Yes,
celiac trunk.
Celiac
Celiac trunk.
perfect. It's celiac trunk. What's this?
Superior
Superior vena.
SMA.
Okay, perfect. What's this?
The gonad. Renal and
Renal.
renal. That's renal.
renal.
What's that?
Gonadal.
Gonadal.
Okay. And what about this?
IMAC.
But extend
Common.
common ileal.
Okay, perfect.
Then internal or external.
Okay, perfect. So let's discuss the celiac trunk in a little bit more details. So we did a lot of details. So Daniela is going to be telling us about different. Okay, just
Okay.
okay. Let's use this slide. Okay, so this is going to be our celiac trunk. Yes. So can you just tell us the main branches of celiac trunk,
So
Daniela?
celiac trunk is divided into three. It gives branches to your common hepatic, your splenic, and your left gastric.
Okay, so it's common hepatic, right?
Yes, common hepatic.
And this is
That.
going to be your splenic, right?
Splenic, yes.
And what else?
Left gastric, supplying the left sarcophagus there.
Oh, okay, this is
Yes.
your left gastric, right?
Yes, left gastric, yes.
Left gastric. Okay. What about further division of your common hepatic?
It's divided into your proper hepatic and your gastroduodenal.
Okay, so this is going to be your proper hepatic. What are the further branches of proper hepatic?
Your right gastric and your other branches, the left hepatic, right, and the cystic.
Right hepatic, left hepatic, and cystic, right?
Cystic.
Okay. What about this one?
Which one is that?
Okay, you can
Your
you just see?
gastroduodenal.
Okay, gastro,
Duodenal.
duodenal. Okay, and what about this branch?
Can I show you? That's the right gastric.
Okay, so it's your right
Gastric, yes.
gastric. What about this one, which is arising from your
Which one?
this one?
Gastric.
That's left gastric. We've already identified that.
Okay, and what about
Level
the
that.
other two branches of your gastro-duodenal? What is the name of this branch?
That's the superior pancreatic. No, that's the
Gastro.
gastroepiploic.
Gastro.
Gastroepiploic, the right gastroepiploic, the greater
Okay.
curvature.
Okay, what about this branch of your splenic?
That's your left gastroepiploic,
Gastro.
both of them for anastomosis. Yes.
Perfect. What about this one?
That's now your pancreatoduodenal, the superior.
It's going to supply your head of pancreas, and it's also
Yes.
going to anastomose with inferior pancreaticoduodenal, which is
Duodenal.
basically derived from SMA, right?
Yes.
Okay, perfect. So if you're going to have ulcers here, which artery is going to be involved? Very high yield? At the lesser
The left
curvature?
gastric.
Okay, left gastric. If you have
Gastric.
ulcer at greater than
The gastroduodenal.
Yes. Yes.
Okay.
gastro-duodenal. Perfect.
Duodenal.
So it was like your entire blood supply. So we discussed that, for example, if you the most high yield point which you guys have to know
Oh,
regarding the
branches
blood
of
supply.
we did not discuss branches of the splenic though.
Yes. Okay. So what are these branches? Perfect.
It gives rise to the short gastric.
Short gastric, and it's going to be supplying the fundus, right?
Yes, the
As
fundus.
you do not have anastomosis here, so it's going to be more prone in
Ischemia and stuff.
ischemia, right? Ischemia.
Yes.
Perfect. Okay. So
Mhm.
as we discussed, if you have ulcers at lesser curvature, so we are going to have involvement of left gastric ulcers at the greater curvature. If the ulcers rupture, it's going to involve your gastroduodenal. So you have your MCQ on that very highly. Okay. So we discussed about Pringle manure. So for example, okay, what is Pringle manure by the way? First of all,
So Pringles maneuver is when the like say when there's bleeding and the surgeon clamps, right? If the
okay,
bleeding it clamps the
okay, we'll clamp which ligament?
the hepatoduodenal ligament because that's where the portal triad is contained,
Okay,
right?
hepatoduodenal
Duodenal
ligament.
ligament.
If still we have bleed, if the bleed do not
Then
stop, then we
that
will
means the
assume
bleeding
that
is coming from the IVC and the hepatic
Good umbilical.
veins. Hepatic
hepatic
veins.
vein. Perfect. That's perfect. Okay. So this was all about your celiac trunk. Let's discuss something about SMA, right? So for the SMA, we discussed is going to supply your midgut, okay, and we have some branches as well. So what's the name of this one, Daniela?
Wait, what?
Okay, this is your SMA, right?
Okay.
Yes, and it like courses above your duodenum, right? We will be discussing a pathology or a syndrome related to that in our further slides. But I want you to just tell me some of the branches of your SMA, the main three branches, I would say, okay? So this is going to be branch number 1, number 2, and your third branch. So can you just name the branch 1?
Idio. It's the ileocolic,
Perfect.
Ileocolic.
What's the second one?
middle colic, and right colic.
Okay, perfect, Dr. Mariam. Right colic and your middle
Middle colic.
colic. Perfect. So Dr. Mariam, can you just please tell us these branches?
Or it's the left colic,
No, left colic arises from somewhere else.
IMA.
sigmoidal,
IMA.
sigmoidal,
Sigmoidal.
sigmoidal.
Okay, they are ileal and vaginal arteries, right? And at their end, it's going to form vas erecta. If you guys remember, let me just show you a picture of that here, right? So here, so in the end, it's going to form arcades and vas erecta, right? So these anastomoses are basically called as arcades, and the branches which are like going out of these arcades are called as vas erecta. Okay.
Mhm.
Okay, so let's discuss a syndrome that is SMA syndrome. So what do we mean by SMA syndrome?
So this is when there's
There-
the SMA, the superior mesenteric artery in the aorta compresses the third portion of the duodenum.
Okay, perfect. So normally we see that SMA is going to run above your duodenum, the distal one-third aspect of your duodenum, right? So we have a fat pad there. So those individuals who undergo excessive fat loss, that fat
Yes.
content pad can be, like you can say like it can melt. And what happens? The SMA and aorta in between they can just compress the duodenum, giving you symptoms, right?
Yes,
Duodenal
superior
aorta,
mesenteric.
okay, like duodenal obstruction. Okay, perfect. So it's basically SMS syndrome, right? So let's discuss about our last blood supply, that is IMA. Okay, so let me just show you a picture of that, the IMA. Okay, so this is your IMA. So here you guys can see it's your left colic branch and your
Sigmoidal
arteries,
arteries.
right?
Mhm.
Sigmoidal arteries, perfect. So it's going to be supplying your hindgut, as we know, and we have dual blood supply as well. So we discussed everything here, right? So this was all about your blood supply, okay? So the last topic here, which we are going to discuss, is your portal veins, right? So can you just tell me about portal venous system? Anything about portal venous system?
It takes the blood from GIT and brings to the liver. And
Okay,
then
portal blood
Fine.
from GIT and bring it to liver, right? So this is going to be our portal vein, right? So you guys are going to be telling me different veins draining into your portal vein. Yes.
Okay, so we have the splenic vein. The splenic vein drains directly into the portal vein.
Okay,
The
so
superior
this is
mesenteric.
your splenic vein, right?
Yes, that's the
Yes.
splenic.
What about this one?
The superior mesenteric.
Okay, and what about this one?
Inferior mesenteric, that drains into the splenic first before it drains into the
Perfect.
portal.
So you can see it first of all is going to drain into splenic vein, your inferior mesenteric, and then in the end it's going to. Okay, and what about these branches? Left gastric vein.
Oh, left
And
gastric vein. Okay.
tibial
Let's
vein.
go. Let's go with the stomach. Mhm.
Yes. giving you esophageal varices. Okay, and what about these two
Left
branches?
case.
The
Yes, they are the hepatic branches of this venous system. Perfect. So we have anastomosis basically at 3 points, right? So you guys are going to be telling me that at first, at the end of your, at the distal aspect of your
esophagus,
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 perfect,
umbilicus, and rectum.
Umbilicus and rectum.
umbilicus,
Rectum.
and
Rectum.
rectum. So, for example, if someone is having portal hypertension, so these 3 sites are going to have a lot of, they have anastomosis with your systemic veins. So we are going to see here esophageal
Esophageal
varices, the most
varices.
common cause of that in cirrhotic liver cirrhosis. Okay. Then we
Yes.
have our umbilicus giving us caput
Caput
medusa
medusa.
and hemorrhoids.
I
Okay.
wanted to ask, anorectal varices, are they the same as hemorrhoids?
No, actually, there is a difference in. Okay, so normally what happens in basically going to give us something like internal hemorrhoids, right? So we have external and internal hemorrhoids, right?
Mm-hmm.
So what happens at this aspect, like normally hemorrhoids are, like venous blood, a tortuous venous blood veins, dilated veins, right?
Mm-hmm.
Is that clear? So
Yeah.
you can, in some aspect, you can say that yes, they are a kind of hemorrhoids, right? But they lies above your
Pectinate line. Okay.
yes, internal hemorrhoids. They can be, or they can be considered as internal hemorrhoids. Okay,
Okay.
the painless. Okay. So our next topic is about hemorrhoids, right? So you guys are going to be telling me internal hemorrhoids, external hemorrhoids, how to differentiate them, their nervous supply, and based on that, you guys are going to be telling me will they be painful or painless? Yes.
So internal.
Internal,
Internal
not
hemorrhoids
painful.
is not painful.
Not
Okay,
painful.
above pectinate. Okay, so
Above.
internal are painful.
Above.
No, they're
No,
not
Painless.
painful.
not
Painless. Why?
Because of
Because they
the
don't have any. They don't have innervation. The visceral innervation, because you don't feel it is big.
Yeah.
Perfect. What about the epithelium?
Endoderm. Columnar epithelium.
Columnar.
Columnar epithelium.
It's simple columnar epithelium.
Simple epithelium. Perfect. For the external hemorrhoids, for example, if they occur here, they are basically painful. Why? Due to the nervous supply is
Innervation.
by
The pudendal nerve, from the pudendal nerve.
pudendal nerve. Perfect. Okay. So this was all about hemorrhoids. So okay. So the next topic which we are going to discuss is basically our anatomy. Okay. So this was your vessel anatomy. Okay. So just give me a second. Okay. So let's discuss some non-vessel anatomy, right? So we discussed non-vessel anatomy in detail, but before discussing that, we need to know about a pathology that is congenital diaphragmatic hernia, right? Congenital diaphragmatic hernia. So Dr. Mariam is going to tell us what is congenital umbilical hernia. No, sorry. Congenital diaphragmatic hernia.
It's a midline defect, and it's because of the umbilical ring problem, and it's associated with the Down syndrome and the congenital hypothyroidism. Basically, the problem is the failure of umbilical ring to close, and that's all. It's because of increased intra-abdominal pressure.
Okay. So my question was congenital diaphragmatic hernia. Congenital
Diaphragmatic. Oh, sorry,
Yes.
sorry. I thought you asked the umbilical.
Yes,
So
I just okay, no. Yes.
yes, the congenital. Yes,
Okay.
the
First of
diaphragmatic.
all, it's a defect
Because
in
of
which
the
membrane?
defect,
Just name
the
that.
pleuroperitoneal membrane defect because of congenital defect.
Perfect. Pleuroperitoneal membrane. So Dr. Daniela is going to be telling us that it's going to lead to lung hypoplasia. Why?
Because don't take me. I'm not. I don't really know that part.
If
Sorry.
you for the lung to fill up, that's why.
Okay. So normally if we have congenital diaphragmatic hernia, so what happens? All of the contents are going to move into the thorax, right? And normally within the thorax, our lungs basically develop. So what happens now as the content of your abdomen are basically present? Yes, due to compression, it cannot grow well. So then it's going to lead to lung hypoplasia. You have a UWorld MCQ on that. And what would be the presenting features? That is scaphoid abdomen, right? And the angiotube would be present within the thorax. You are going to see some bowel sounds within the thorax. Okay, which isn't basically a normal findings. Okay, so let's discuss next type of hernia, that is acquired hiatal hernia, right? So we have different variants, that is sliding hiatal hernia, paraesophageal hiatal hernia. So doctor, who is going to be telling me sliding hiatal hernia in entire details that we discussed? Yes, please raise your hands, those. Okay, Dr. Judith. Judith is going to be telling us about sliding hiatal hernia.
Okay. The in sliding hiatal hernia, the gastroesophageal junction is displaced upward.
Perfect.
Yeah. Yeah, at gastric cordia. Yeah. Slide into the hiatus. Yeah.
Okay, so the
It will
gastric
give
cardia
us
is going to
our
herniate
stomach.
through the.
Yeah.
Okay, so the gastric cardia basically is going to herniate like through the gastroesophageal junction, and there are some of pathologies associated. So, for example, if you have disruption of gastroesophageal junction,
Yeah,
it's going to
it's
lead to increased
associated
risk
with
of.
that. Yeah. It's
Oh
associated
yes,
with that. Yeah.
GERD, right?
Yeah.
Gastroesophageal reflux
Esophageal
disease.
reflux disease. Yeah.
Perfect. What else? Mallory Weiss-Steer, these two things. So, Dr. Judith is going to tell us in detail if someone is having GERD, just please, I need you to associate it with Barrett esophagus, adenocarcinoma of your lower, and metaplasia and all of that stuff. I want that association.
Okay. The GERD is normally associated with adenocarcinoma of the esophagus, right? Yeah. So is it the presentation that you want?
Okay, okay. I want you that, for example, if the acid content is moving upward at the, like to the lower one third of
Yeah,
esophagus, then we are going to have step by step. We are going to have metaplasia. If you have metaplasia, so the epithelium is going to change from which kind of epithelium to which kind. I want you to just tell me that.
Columnar.
Okay, from the squamous to columnar. Once that's changed, it's basically known as Barrett esophagus, right? And in the Barrett's esophagus, there is increased chances of getting adenocarcinoma at the lower one third. So for adenocarcinoma, we discussed that we first of all need that we must have Barrett esophagus or we must have metaplasia there in order to get adenocarcinoma. That's why adenocarcinoma is only seen in the lower one third of your esophagus. Is that clear?
Yes, and the patient presents with heartburn, regurgitation.
Yes, heartburn. Perfect.
Yeah.
So like it can be confused with MI, right?
Yes.
Yes, perfect. Okay. So can anyone just tell me what is Mallory Weiss-Steer? Dr. Daniela, please.
Oh, Mallory Weiss-Steer, that's a longitudinal mucosal tear at the gastroesophageal junction. It's mucosal. That's how to differentiate it with Boerhaave. Boerhaave is transmural because the inverse.
So if we have transmural, it's going to end in Boerhaave, right? So you are boring basically. So all of the air is going to, move into your thorax. It's going to give us subcutaneous emphysema as well, right?
And
like
and malaria is usually caused by the retching, like seen in like alcoholics and bulimics, like the
Why?
The pressure due from the vomiting and the retching, the forceful.
Yeah, so this increased vomit pressure is basically going to tear this lower, or it's going to cause like longitudinal tear. Perfect. So our next pathology which we are going to discuss is paraesophageal hiatal hernia, right? So Dr. Shafiq, can you just please tell us about what is paraesophageal hiatal hernia? Yes. How do one get that?
Paraesophageal hiatus hernia.
Yes.
Yeah, this is due to when the fundus will go. You mean the when the fundus will be herniated into the above the diaphragm, it will be the paraesophageal hernia.
Perfect. So whenever the fundus get herniated and it gets at the paraesophageal aspect, so it's going to lead to paraesophageal hiatal hernia, right? So it's normally again associated with bowel sounds, seen within the auscultated within the chest, which isn't a normal finding, right? So this was all about our hernias.
Doctor, is it also related to that is called laxativity of the diaphragm, like then the ball?
Okay, so the idea here is that whenever, again in paraesophageal hernia, whenever there is defect in the membrane, right? Defect in the membrane, for example, your diaphragm membrane, right? So again, what happens? Okay, let me just draw it so everything is going to be like more simple, right? So for example, if this is our diaphragm, let's suppose this is our esophagus and your stomach, right? So for example, if this part of the membrane mostly at the right side or left side?
Left side.
Right? Why? Because at the right side we have liver, right?
Left
So
liver.
for example,
Yes.
if here we have problems with this membrane, defect in membrane. So what happens? This fundus can just herniate outward. It's known as paraesophageal. What do you mean by paraesophageal? Like it's present in close proximity. Para, right? These are the terms which basically describe this pathology. Paraesophageal herniation, right? So for the laxicity, simply you can think of if there is like weakening of this portion, or if it's more like laxive, so it can reach to this pathology. Is that clear?
Sir, I have a
Yes, clear.
question. Sir, sliding and paraesophageal, they are different kinds of diaphragmatic hernia?
There are different kind. Okay, they are hiatal hernia, right? So for the paraesophageal, if there is problem within the diaphragm, then it's going to be paraesophageal. But as we discussed in sliding hiatal hernia, there is like problem with the sphincter, right? Here. So if we have problem here, so then this part is going to herniate up within your esophagus. Is that clear?
Yes.
Yeah. So these are the two different types. Okay. Of diaphragmatic hernia, you can say problems with the diaphragm. Okay, so let's discuss our three last and important hernias that are direct hernia, indirect hernia, and femoral hernia. So we discussed that in a big detail. So I want you guys to be telling me that. Okay, so let's pick someone else okay, Dr. Ramesh. Dr. Ramesh is going to be telling us about indirect hernia. Yes.
Okay, so indirect hernia happens when there is the processes vaginalis fails to obliterate, and the bowels or intestinal loops travel from the deep ring to the superficial ring and then into the scrotum.
Perfect. So actually, it's basically failure of the process vaginalis to invaginate. So what happens? It's going to move all along your inguinal canal, right? So it's going to be having all of the layers. So can you just tell me the layers of your spermatic cord? Hello?
Okay, I don't remember the layers.
Okay. So as we discussed, normally the testicles are also going to move here, and it's going to drag like the 3 layers along with itself, giving rise to your spermatic cord. That is internal spermatic fascia, cremasteric muscles, and external spermatic. Right? Is that clear?
Yes.
Okay. So as these herniated contents are moving, also they're also going to take. Okay, which nerve is present here? By the way, yes. In the inguinal canal, we just have a nerve. What's the name of that nerve?
Ilioinguinal.
Ilioinguinal. Okay, perfect. So the pathophysiology is that basically, as Dr. Ramesh just tell us, we are going to have herniation starting from the internal ring, and it will be protruding out in the external ring. One important thing which you should just tell me, Dr. Ramesh, would it be present medial to your epigastric vessels or lateral?
It should be lateral to the inferior epigastric vessels.
Yes.
Okay, lateral to inferior epigastric vessels. Perfect, right? And what about direct hernia?
Yeah, it happens
Medial.
because so it will be medial. Yes.
Perfect. That's like two important things which you guys should know. Okay. So let's discuss our direct inguinal hernia. So for the direct inguinal hernia, what's the main risk factor? One of your UL MCQ. Yes, doctor.
Weakness of abdominal muscle.
Weakness of
Weakness.
transverse.
Transversalis fascia.
Weakness of the transversalis fascia. Okay. So we have a triangle in which it's going to arise. What's the name of that triangle?
Hasselbalch.
Hasselbalch triangle. Perfect. And again, let me just ask again very highly. That's why I'm just asking it again. Would it be present medial or lateral to epigastric vessel?
Medial.
And it's only
And
going to
these
have
don't
a
lie.
single. Yes, it's only going to have a single layer of your spermatic cord. What is the name of that?
The external.
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 External
Perfect.
fascia.
Perfect. Only the external. Okay, perfect. So let's discuss our last hernia, femoral hernia. So mostly it's going to be seen in women,
Women.
right?
Females.
Female.
Women
Okay.
below,
So we
below the
have
inguinal
femoral.
canal.
Yes, yes, yes. Please.
Below the inguinal ligament through the femoral canal.
Below the inguinal through. Okay, perfect. Below inguinal in the femoral
Ligament
canal.
through the femoral canal.
So we have a femoral sheath. Can you just tell me the content of femoral sheath? What are present within the femoral sheath? What
The
is present
femoral,
outside?
Artery, vein,
AV,
And
the artery,
Are
vein,
when
and
and
Navo.
lymphatics.
yes.
It can
Okay,
be
please one
navo
by one.
from lateral. Yeah, it can be navo from lateral to medial.
Okay, perfect. Okay. So the nerve is only going to be present like outside the sheath. Okay. And what would be the presentation? Again, we will be having a lump inferior lateral to the pubic tubercle, and it's more going to be seen in women as with by comparison with men. Okay. So with that, our embryology bootcamp have ended, our anatomy ended, and we are going to start our physiology, right? So before discussing physiology, let's have 5 minutes of break. Okay. Is that okay? So see you
Yes.
after 5 minutes. Thank you.
Yes, doctor.
Okay, thank you, doc.
Yes, doctor.
So anyone knows what doctor was telling about the nerve? Was it related to indirect or direct inguinal hernia?
No, he just asked the nerve that is contained in the spermatic distance that goes in the
Uh,
Inguinal
inguinal.
canal.
Yes,
like
inguinal canal.
ilioinguinal nerve. Yes,
Like
ilioinguinal nerve.
yes, what runs in the inside the inguinal canal? Your spermatic cord, ilioinguinal nerve, and the genital branch of the genital canal. Yeah.
Oh, okay, great. Thank you.
Welcome.
Hello. Can anyone explain about the nerve artery and vein relationship in the femoral hernia?
Hi, sir. It's not like the femoral hernia. The sheet he was
Yeah,
asking
the
what.
femoral sheath. Yes.
Yeah, so the you know there's the nerve, the artery, the vein, and the lateral, like from the lymphatics from lateral to medial, right? But in the sheet, in the femoral sheet, only the artery, the vein, and the lymphatics are contained in the sheet. The nerve is outside the sheet.
So okay, and then it's related to
Dr.
which
Ahmed
ligament?
raised his
Inguinal
hand.
ligament?
Femoral.
No, femoral. Yeah, but then they ask about the relationship, right?
So
Uh,
it's the mnemonic is the nav, NAV, from lateral to medial. So the nerve is laterally and then artery, and then vein.
No, I think what she
And
means
most
is that
medially are
lateral
the lymph
to,
nodes.
Dr.
like
Mariam, she's
lateral to
asking.
what?
She's
Lateral to what?
Lateral, no, it's just the location or the position, as the nerve is most laterally, and then the femoral artery. After that, we are going from lateral to medial, then the femoral vein, and most medially are the lymph nodes.
Like in
it's not
lateral
like,
to what?
sorry,
What is the
with Dr.
landmark of
Ahmad.
lateral? Is it the pubic tubercle or the
It's
symphysis? Like
Yes,
lateral to that?
it's pubic
just
tubercle. These are all the structures are lateral to the pubic tubercle, as the pubic tubercle is most medial structure.
Yes, that's what I mean. Thank you, Miriam.
Welcome.
Okay.
Yeah,
Thank you.
and the location of the artery is like at the middle of the thigh. So, in that respect, the mnemonic is navel in nerve, artery, vein, and lymph node. And we can remember it like it's pointing towards the navel. So, navel or the umbilicus. So, it's navel.
Oh, great. Yeah, that makes sense.
Hello? Hello? Are you guys here?
Yes,
Yes,
sir.
yes. Thanks for
Okay,
you.
perfect. Okay.
Yes, doctor.
So, why are so many participants leaving? What happened? Okay, so let's start our physiology, right? So we will starting physiology with discussion of different hormones, digestive hormones. So I'll be selecting some of you guys. You'll be just telling me the functions and everything, right? Okay, so starting from Abdur Rauf. Abdur Rauf, can you just please tell us something about hormone? So what you are going to be telling us, the site or the location or the cells which secrete gastrin, its regulation, its action, and if you have some other stuff in your mind.
Yes, sir. So, sir, basically the gastrin is secreted by the G cells, which are located in the antrum and
Perfect.
antrum of the stomach and some part of duodenum. And the
Okay.
main action is to basically increase the acid secretion, the H plus secretion. And
Perfect. On okay, with your gastric HCl secretion, right? So for
yes,
the parietal cells, we have three main important stimuli, right?
yes,
One
sir.
gastrin, acetylcholine, and histamine, right? So all of
Instrument.
these three things can increase the secretion of your parietal cell, giving us HCl. Okay. How do we have release of gastrin? What are the regulation factors, regulatory factors?
Sir, it is actually regulated by the distension of stomach and
Perfect.
and also by the vagal stimulation, and also when there's the pH is when going up, like alkalization is happening. So
Perfect. And peptides as well. If you have more peptides, we need more gastrin, we need more gastric acid, right? And some
yes,
high yield point, what happens in Zollinger-Ellison syndrome?
in the Zollinger-Ellison syndrome, sir, basically there is a tumor, the gastrinoma, which is secreting too much of this gastrin and causing increased pH.
Perfect. What about atrophic gastritis? If we have atrophic gastritis, we discussed that in detail.
Sir, I think that atrophic gastritis, basically the parietal cells are atrophied and
Yes.
they cannot.
And if you do not have HCl, the negative inhibition is lost. So what will happen to the G cells? Hyperplasia, right?
Hyperplasia of the G cells.
Perfect. That's perfect. So, okay, Dr. Victor is going to be telling us something about somatostatin. Yes, Dr. Victor, can you just please turn on your mic? Okay, Dr. Mariam, can you just please tell us about somatostatin?
Yes,
It's
somatostatin is released from the D cells of the GI
perfect.
mucosa and the pancreas, and it has the
Where are they
inhibitory
present?
effect. These are
In the
present in
antrum.
the GI mucosa,
This is
distal
antrum.
antrum of the GI, stomach, and the
Okay,
pancreatic islets.
islets, perfect. Okay, what are the actions of
It
somatostatin?
has the inhibitory. It has inhibitory effect over the gastric secretions, gastric
Mhm.
acid secretions, and the pancreatic, and the as well as the small intestine fluid secretions. And it also have the inhibitory effect over the gallbladder contractions, and the
Perfect.
insulin and the glucagon release.
Okay,
Uh,
perfect. So how do we, what are the regulatory factors?
Vagal stimulation and the
Increase vagal or
AC.
decrease vagal stimulation?
It is decreased by vagal
Decrease.
stimulation.
Okay. Okay, decreased vagal stimulation. Okay. So as we have a drug octreotide. Can you just please tell us about how, okay, what's the use of that
It's a
drug and
somatostatin analog,
analog?
and
Perfect.
it is given for the treatment of carcinoids, lipoma, and the
Acromegaly.
acromegaly, and the also the variceal
Esophageal
bleeding,
varices too.
esophageal
Yes,
varices.
esophageal varices. Perfect. So Dr. Shafiq is going to be telling us about CCK, cholecystokinin. Yes.
Yeah, cholecystokinin. This is from its name imply it's kinetic for the bladder. So it's secreted
Which
from the eye
cells
cells.
release it? Okay, let's start from the beginning. Which cells
Yeah,
release it, and where are
it's
those cells present?
the eye cells, which is
I
present
see.
in the duodenum and the early jejunum.
Okay, perfect. What are the actions?
The action, it will be increase the gallbladder contraction and relaxation of the sphincter of Oddi,
Perfect.
and also increase also the pancreatic secretions.
Perfect. Okay. What about regulation?
It will increase by the arrival of the amino acids and the fatty acids to the
Fatty
jejunum.
acids. Perfect. Perfect. Okay. So let's discuss our next hormone, that is secretin. So Dr. Judith is going to tell us about secretin, the cells which release secretin, what are the actions of secretin, the regulation, and everything. Yes. Hello. Okay, Daniela, can you just please tell us about secretin?
Oh, okay. So secretin is secreted from the S cells of duodenum.
Perfect.
And its main function is it increases the what's it called, the pancreatic bicarbonate, right?
Perfect. Okay, so bicarbonate is basically further used to neutralize your chyme, right?
Yes, you're
Okay.
kind of.
So what about the regulation?
When there's like increased like fatty acid kind of thing, like increase.
Perfect. Okay, so Dr. Kizzy, K-I-Z-Z-Y. Can you just please turn on your mic? Hello? Hello, Kizzy, can you just please turn on your mic? Inaya?
Yes, sir.
Inaya?
Yes, sir.
Okay, Inaya, can you just please tell us about GIP, gastric inhibitory peptide, or glucose-dependent insulinotropic peptides?
So, sir, this is secreted from the K cells of the duodenum and the jejunum, and they help in increasing the insulin and decreasing HCl.
What's their action?
Increases insulin and decreases the HCl.
Okay, we have two group of individual. One just take oral glucose, other IV. So in which kind of individual we are going to have more insulin release? One of your you will MCQ. Yes, and why?
Oral.
Oral. Why?
Because for the release of this peptide,
GIP. Yeah.
GIP secretion.
Okay, perfect. So let's discuss our last hormone, that is VIP. So Dr. Margaret is going to be telling us about VIP. Yes.
Yeah, the VIP is
We can't hear you well.
the VIP. Can you hear me?
Yes, we can hear you now.
Yeah, the VIP is parasympathetic ganglia, and
It's released from your intestine. Okay. Okay, perfect. Increase intestinal motility, and along with lower esophageal sphincter relaxation, right? And if we have VIPoma, what is VIPoma?
VIPoma is a non-alpha and a non-beta islet.
Okay, perfect. Watery diarrhea, hypokalemia, and acholoria. Okay, perfect. So it was all about the hormones. Let's discuss some gastric acid secretion. Guys, please be a little bit more enthusiastic, or just show some enthusiasm, because you guys are just going down. Okay, so let's discuss about parietal cells. Okay, so for the parietal cells, who is going to be telling me the functions of parietal cells? It's secretion. What? Yes. Hello.
Yeah, I can.
Okay.
Yeah,
Yeah.
parietal cells will secrete the acid. It will secrete the HCl.
Okay, what
Um,
else?
and also they will secrete also the intrinsic factor, which will
What is
help
the intrinsic factor important for?
for it will attach to the vitamin B12 to be absorbed in the terminal ileum.
Okay, so can anyone just tell me R binder and B12? First of all, pancreatic protease is going to cleave us if we have failure of that. So we are going to have ADEK deficiency. Do you guys know that? You world MCQs?
Yes.
Yes.
Okay, okay, perfect, right. Okay, so what are the stimuli for the release of HCl? As we discussed, three things: HCl, acetylcholine, and gastrin, right? Okay, what
Yes.
about cleave cells?
Chief cell will secrete the digestive enzyme, which is the pepsin.
Okay, pepsinogen. So pepsinogen is a zymogen, and it's going to be converted into pepsin, and then it's going to cleave, different peptides. Okay. So, okay, for the bile, let's discuss. Okay, a little bit about bile, the physiology, right? So let me just give you an overview. For the bile, we discussed that cholesterol is going to be acted by an enzyme, cholesterol 7 alpha hydroxylase, right? And then it's going to be converted into bile acid. For the bile acid, we need it to be like combined with two things, glycine and taurine, right? Giving you bile salts. Remember? Then it's going to become water soluble, right?
Yes.
Oh, okay. So let me just draw it. Okay. Okay. So we discussed that bile is basically produced by your liver, right? And it's stored within the gallbladder.
Yes.
Right? Okay, so we discussed how the bile is made. We discussed that we have cholesterol. Cholesterol is first of all going to be acted by an enzyme, cholesterol 7 alpha hydroxylase. Now it's going to be converted into bile acid. Bile acid is going to be combined with glycine and taurine. It's going to be converted into bile salts, right? And bile salts can further bind three things, that is phospholipids and cholesterol and cholesterol, right? What else? Bilirubin
Bilirubin.
and ions and water, because they are water soluble now. Okay, so it's basically stored in gallbladder, and as we discussed that for the release of bile, we need CCK to contract our gallbladder and relax the sphincter of body, right? So the functions, basically we discussed that digestion and absorption of lipids, right? The cholesterol. What else we discussed that it's going to prevent calcium binding to fat. If we have calcium binding to fat, what happens? We'll be having free oxalate absorption, and free oxalate absorption is going to give us calcium oxalate strong. Crohn's disease, remember what happens? The ileum is going to be disrupted. If the ileum is disrupted, if you have inflammation there, we cannot reabsorb bile. Did you guys remember that?
Yes, sir.
Yes.
Yeah, so if you are losing a lot of bile, what happens? We are going to have increased oxalate reabsorption, which is going to lead to calcium oxalate, right?
Sorry,
Yes.
can you come again, Dr.
Yes.
Ahmed? Starting from cholesterol. Sorry.
Okay,
Yes.
sorry, can you please?
Yes, can you repeat again from cholesterol, please?
Okay, so cholesterol being acted by an enzyme, cholesterol 7 hydroxylase, 7 alpha hydroxylase. It's going to be converted into bile acid. It's an acid. So we are going to combine it with some bases, right, in order to get salt, because the reaction of acid and base basically give you salt. We know that. Okay, so the bases here are going to be glycine and taurine. Once it's combined with glycine and taurine, it's going to give us bile salts. And what are the function of bile salt? It basically, it can solubilize your cholesterol. It can bind cholesterol. It can bind bilirubin. So in this way, we can eliminate bilirubin, which is going to be our next topic, right? What else? It's also going to be water soluble, right? So it's also going to bind with some ions and water as well, right? So what are the function? The function are digestion and absorption of lipids, right? Okay. What
Thank
else?
you.
It prevent calcium to bind with sauce, with your fats. If the calcium bind with fat, what's the problem? It's going to lead to reabsorption of oxalate as well. If oxalate are reabsorbed, it can lead to calcium plus oxalate stones. Like in Crohn's disease, we know that it's basically inflammation of your colon, right? And your small intestine can involve as well. So we know that bile acids are being reabsorbed in terminal ileum, right? So if we have inflammation of ileum, bile cannot be reabsorbed. So we are going to have bile deficiency, right? If you have bile deficiency, what happens? You'll be having bilirubin stones, right? because now you cannot eliminate. Okay, you cannot reabsorb bile in order to again combine with bilirubin and excrete them out. Okay, what else we can? Okay, cholesterol can also not be like solubilized and in turn further convert into bile. So we are having increased chance of cholesterol strong as well. What else? Now calcium would combine with fat, as we discussed, if we do not have like bile in case of Crohn's disease. So it is going to lead to, yes, oxalate stones.
Oxalate
Solid
stones.
stones.
Renal stones. Perfect. Okay. So the next topic which we'll be discussing is bilirubin, right? So we discussed bilirubin in a great detail. So I want you guys to tell me, right? How do we get bilirubin? Different intermediate steps. Can you just please tell me what is direct, what is indirect bilirubin, and different pathologies which can lead to jaundice and things like that. So who is going to be telling me that?
Yeah, I can.
Yes, please.
Yeah, the direct bilirubin, it can come from the hemolysis of the red blood cells. Okay. And after that, it will be taken by the liver, and it will be conjugated.
Okay.
And by an enzyme called UDP something glucuronidase.
Glucuronidase transferase.
Yeah, glucuronidase transferase. It will be converted to direct bilirubin, and after that, it will go into the it will be transformed to be with a gallbladder and excreted. So sometimes if there is extra hemolysis, there will be overburden of it, and this will lead to increase of the direct bilirubin, which we can see it also in what is this? The Gilbert syndrome. Yeah, and
yes, please.
And the second step could be with what is this? Najjar syndrome, and the other one is
That's
called.
Najjar syndrome. We will be discussing that. Okay.
Yeah,
So
thank you.
actually, what happens that basically we get bilirubin from heme metabolism, right? So it's going to be converted into biliverdin, then unconjugated bilirubin. It's going to bind with your albumin. It's going to be taken into your liver. There you have UDP, glucuronidase transferase is going to convert it into direct bilirubin, right? Okay, and
Yes,
direct
sir.
bilirubin is going to move like in your gut, and by your gut bacteria, it's going to be converted into urobilinogen. Urobilinogen further is going to be reduced. If it's reduced, like if it's more reduced, it's going to be converted into stercobilin, which is going to give the stools its brown color, right? And
Yes.
if it's less reduced, it's going to be converted into urobilin. And the urobilin is going to be absorbed in the blood and is going to be excreted in urine, giving you yellow color of urine, right?
Yes.
Perfect. That's perfect. So in different pathologies, for example, as doctor just told us, if we have extravascular hemolysis, a lot of unconjugated bilirubin is going to be built, it's going to be conjugated. It can just, leak into the blood, giving us jaundice, scleral icterus, which we'll be discussing in our further lectures. Okay. So in cirrhosis and hepatitis, important thing which you guys should just keep in mind, we have elevation of both conjugated and unconjugated,
Conjugate,
right?
yes.
Perfect.
Yep.
And in the heredity hyperbilirubinemia, which we'll be discussing in our pathology section, Gilbert, Krieger-Nagar, and Dubin Johnson. So let's just leave it to that, okay? Okay, so it was all about bilirubin. Let's discuss something about exocrine pancreas, right? So for the pancreas, the exocrine function, we know it just releases a lot of enzymes, right? And these enzymes are basically, can you just name them? Anyone, please?
Amylase, amylase,
Okay.
lipase, protease.
Lipase, protease, alpha amylase. Perfect.
Yes.
Okay. So regulated by CCK, secretin, remember? Lipase
Yes.
for lipid digestion. Protease, further have trypsinogen, chymotrypsinogen, proelastase, procarboxypeptidase, which are zymogens, which have to be converted into active form. That is trypsin, chymotrypsin, elastase, and carboxypeptidase. Is that clear? The only
Yes.
one which is released in a matured form, not a zymogen, that is alpha amylase, right?
Yes.
Okay, perfect. So it was all about our physiology. So we discussed like the most high yield things in our physiology. So now we'll be discussing our pathology section, right? So is that okay? Are you guys just enjoying it or not?
Yep,
I think
yep,
you guys are
Yes,
just,
we are.
yes. Okay, you must be enjoying that. Okay. 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 Just give me 1 minute. Just let me just open my notes. Okay, who are planning to give their NBME next week? We are arranging another NBME. Those who have booked their exam, those who are added in that accelerated group, if it's last chance for you guys. If you guys didn't give your NBME exam, only those who have given will just like let them be in the group, right? We'll be removing all of the others. So it's our last call. Those who want to participate in the upcoming NBME, just give that. Okay.
Sir, like we feel little unprepared for that as we have few things to cover and we are scared
Yes,
that we
if
will
you
fail.
Yes, like
okay,
me.
so let me just tell you. You guys, okay, I just asked you guys who are going to give your exam. You guys just told me that yes, in the upcoming months we will be giving, right? So based on that, we just made that group. So those who want to stay there, just give their NBME. We'll be guarding you, right? Those who want to stay here, they should just stay here, no problem. They should just follow the normal marathon.
Doc, can you just hello?
Yes, please.
Okay, okay. Can you just like shed some more light on this accelerated group? Like what's is going to be there and what's the
Okay. So in
curriculum
the
will be?
accelerated phase, basically, we are going to provide you a mentorship. We won't be having classes. If you guys still want to take classes, already the marathon is going on, you should just take classes there, right? So in the accelerated phase, what we have planned is we'll be giving you personalized guidance, right? So if we will be first, like after looking your NBME score, we will at least know your where you are standing, right? Based on that, we'll be just telling you to which resources to follow, how to fine tune. If you're like, we'll be just like more personalized to individual. If anyone, like there are most of the students who are having problems with certain subjects, so we will be guiding them that you should just do it like that. If you guys have any problems or like on your MCQs solving tactics, so we can just give you that. And mostly we won't be having lectures there, because now those who are about to give their exam, they do not need any lectures, right? If still they want lectures, they can just join the revision session, right? But we'll be just fine tuning your your preparation, right? What you need. And Dr. Moaz is going to be there, Dr. Aliza is going to be there, I'm going to be there, and we are going to be more personalized to those people. Okay.
Yeah, okay. So, Doc, like for them, for those candidates like who have the exam after in the month of like June, July, or something like that. So, like for after 2 months, for the next 2 months. So, will we have an accelerated batch for the for them
Yeah.
for them?
Yes, obviously, as the groups are here, we won't be, you can, like, right after this program, you're just open to all of the resources. We won't be removing any resources. The groups would be there. You can have conversation there. If you feel that most of you guys are prepared, and if most of you guys need that accelerated phase, like as you guys see that many of the students wanted that, right? So after your preparation, like even if you are about to give your exam right after 1 month, 2 months, if you don't want to join the next marathon, that's completely okay. But I suggest just do some self-study, right? That's also important. And in that group, like we'll just keep open the USMLE family group along with that, the marathon group. So you guys can just, like on demand, I would say, you can just make those groups. We'll be helping you in your NBMEs as well as in accelerated phase. So we are here. You guys are already here. Don't be worried, right? So it's going to be for all of you guys. And we won't be just, turning off the, the messages there. You can just have conversation. You can connect with us and everything is going to be there, right?
Yeah,
Sir,
Doc.
I had a question,
Thank you
sir.
so much.
Yes,
Sir,
please.
sir, where can we find your previous videos? Like I wanted to do the immunology and then the boot camps that you provided for a cardiovascular for that quick revision. But
Okay.
where can we find, because we joined the January batch, right? So it's a bit difficult now. We can't find your previous videos.
It would be better if you guys ask the previous platform, because it's their responsibility to provide the previous things, and I do not have that in the recorded phase or recorded. So it would be better to ask them, because you have paid them for everything and still the marathon is going on. If you want those recordings, so just tell them, they'll just provide you, right?
Okay, sir.
Yes. As you know that from hematology onwards, I can just provide you. That's your, on our YouTube channel, I'll just give. But for the previous, I think, I can't do anything. Sorry.
So, Dr. Ahmad, I have one question.
Yes, please.
So, in case of May session, as I am just entered this phase in the beginning of the April, so when our like May session will start like the beginning session, because
Okay. We'll be starting on 1st May as we have already announced, right? The next batch will be starting on 1st May, right? And we are going to do a little bit more changes because like we have seen a lot of things. Like as you know that this batch was completely like with the NextGen Usmle it was free, right? So basically we wanted some experience, and based on that experience we are going to bring some more things onto our next marathon as well, right? So we'll be having what we are planning, that we'll be having entire UWorld classes as well. As you know that we have collaborated with official UWorld. They're going to provide us the UWorld University, where we are officially allowed to discuss UWorld, and we are officially allowed to keep track of your progress. So yes, we are going to start it from on 1st May, right?
okay.
Yeah, perfect. So let's start our pathology, right? So the first, okay, just give me a second. Okay. Okay. So we'll be discussing pathology now, and the first disease which we'll be discussing is, okay, just give me a second. So we'll be starting from, okay, T fistula we discuss. Okay, just give me 1 minute, okay. So oral cavity, right? So the first pathology is aphthous ulcer. I think it's simple. So who's going to be telling me about aphthous ulcer?
So those are just like painful sores in the mouth.
Okay.
Yes, they are usually like covered by is dates, but they are usually seen they're associated with like celiac disease,
Okay.
IBDs. Yeah,
IBD
IBD.
is for, so it's basically they're associated with some stress, right? Some
Yes,
stress.
that's stress.
Yes, okay. So they're painful superficial ulceration, by the way, okay? So what happens, they resolve spontaneously, and most of you guys might be, having that in your life. Okay, so the next one which we are going to discuss is oral herpes. Again, it's a simple one. So who is going to be telling me about oral herpes? So I'm expecting, in pathology section, I'm expecting you guys to be, answering me quickly, and I'll be just checking some right? I'll be just asking some questions. So oral herpes, who is going to be telling me about oral herpes? Yes. Just wake up, please. You only have pathology remaining.
Oral
Then we'll be
herpes,
having,
it's because of the herpes simplex virus 1.
okay,
And
do
we
you
see
guys need
that,
any break? I think you guys
yeah,
need some break.
yes.
Okay, so let's have 15 minutes of break. Just close your books, close everything. Just go enjoy, and let's see you after 15 minutes, right?
Okay.
Hello? Is it okay?
Yes,
So
needed. Yes,
we will be back at 2:20, Doc, or
15 minutes.
After
15 minutes.
15 minutes. 15 minutes. It's a
Yeah,
big break. Just enjoy that.
thank you.
Hello. Hello. Are you guys here?
Yes, we are.
Okay. So we started with 45 participants and we are only left with 28. So I don't know what happened, but okay. So let's start our discussion on oral herpes, right? So just guys, just please bear me for next 40 minutes and everything will be finished. Okay. Okay. So can anyone just tell me about oral herpes? Okay, please raise your hands. Yes, guys. Yes. Dr. Amis, Dr. Daniela.
Yes, sir.
Okay. About oral herpes.
It's just it's kind of it's like chancres caused by herpes simplex virus one.
Okay, perfect. So we have HSV1, right?
Mm-hmm.
Okay. So can you just tell me some of the presentation, like we'll be having vesicles and something about shingles. If you can just tell me that, please.
Shingles is reinfection.
Okay. So as we are talking oral herpes, so we'll only be having vesicles involving the oral mucosa, right? And it can
Yes.
rupture, it can just develop into like shallow, painful ulcers. And what are the common inciting events which causes oral herpes? As you know that this virus love to stay dormant within the ganglion, especially the trigeminal ganglion, if you guys know that. So with
Yes.
stress or sunlight exposure, they can become reactivated, and further it can lead to oral herpes. Perfect. So the next topic which we're going to discuss is squamous cell carcinoma, right? So we discussed squamous cell carcinoma in a big detail, right? So Daniela is going to tell us about squamous cell carcinoma, its risk factor. You're going to tell us about the dysplastic condition. You're going to tell us different pathologies and or like associated with can be confused with squamous cell carcinoma, the leukoplakia, yes, everything.
Okay. Squamous cell carcinoma, like
Okay,
it's
let me just ask you
what's it called?
questions and answer. Okay, is it a benign neoplastic proliferation of your squamous cell or malignant?
Is malignant.
Okay,
Is
what are
neoplastic.
the risk factors?
Tobacco use and like alcohol use and stuff like that.
Okay, perfect. So chronic irritation, right? They're going to
Yes,
cause
chronic irritation.
chronic irritation.
Yes.
What is the most common location of squamous cell carcinoma? In mouth?
In the mouth. Oh, the tongue. The
Floor,
tongue.
floor of mouth.
The floor of the mouth. Okay.
Okay, perfect. So we have a dysplastic condition that is leukoplakia, right? So leukoplakia is a white plaque. But if we see white plaque, it can be confused with oral candidiasis. It can be confused with hairy leukoplakia. So can you just please differentiate how are we
The
going to differentiate them?
the difference is the plaque is not scrapable, with oral candidiasis and stuff, if you use something to scrape it, it comes out. But with squamous cell, it does not.
Perfect. So if we can scrape it off with a tongue repressor, basically it's oral candidiasis, right? Which is basically due to in immunocompromised states or those who are using glucocorticoids, or like in asthmatic patients like them. Okay, and here is leukoplakia. Here, okay. Can you just tell me if you have two conditions, leukoplakia or erythroplakia, which one is most close to, like more close to squamous cell carcinoma?
Erythroplakia, because then he has
Right?
blood supply, like angiogenesis and stuff. So that's more closer.
Angiogenesis.
Yes.
Perfect. So it's going to appear red. Perfect. Can you just tell me something about mumps, the virus?
Yes, mumps.
Yes.
Mumps is a virus that causes parotid gland
Inflammation.
Inflammation. Yes, parotitis.
What else?
Orchitis.
Okay, orchitis.
Orchitis, yes.
What else? Pancreatitis, aseptic meningitis, right? Okay, perfect. Okay, so let's discuss some of the tumors of your salivary glands, right? The first one which we are going to discuss is pleomorphic adenoma, which is the most common benign tumor. So I want Dr. Mariam to tell us something about pleomorphic adenoma.
Yes, so pleomorphic adenoma is a total benign tumor, most common of the salivary gland tumor, and there is the bilateral parotid gland enlargement seen in it, and it's on histologically it's composed of chondroid matrix stroma, and what else?
Okay. Can you just tell me that will there be any signs of facial nerve damage or pain, I would say?
With the pleomorphic adenoma?
Yes.
No.
Yes,
pain.
we see. No, I think the facial nerve involvement in the pleo.
It's painless.
Sorry,
It's a
when there's facial nerve involvement is malignant, so pleomorphic is
Mm-hmm.
not. So
It's
there's
not.
not.
It's benign. Yes.
It's a
Perfect.
painless.
It's not. It's not. Okay.
Mm-hmm.
Perfect. That's perfect. Okay. So usually we are going to see it like at the angle of jaw, well circumscribed mass. And okay, let's discuss our next tumor, the second most common Warthin tumor. Can anyone just tell me something about what is it, a benign or malignant?
Benign.
Benign. Perfect. Right. Okay. So what are we going to see on histopathology here?
There will be germinal centers.
Germinal centers and lymphocytes, indicating some kind of lymphoid tissue being present. And what's the actual pathogenesis? That due to failure of separation of lymph nodes from this area, we have some remnants of lymph node tissue, right? And those remnants can just develop into Warthin tumor. Our last tumor is mucoepidermoid carcinoma. If it's carcinoma, it means it's malignant. It means it's going to involve your facial nerve. It means it's going to be painful. What else? If mucoepidermoid, mucinous plus squamous cells being seen here, right?
Yes, sir.
Yes.
Perfect. So esophageal web. Who is going to be telling me esophageal web? Yes, guys, please wake up.
Esophageal web is just thin protrusion of the esophageal mucosa.
Okay, it's a protrusion of mucosa. If we have protrusion of mucosa, is there any chance of getting squamous cell carcinoma? If yes, so I need the reason. Why?
Yes.
Because chronic irritation.
Chronic irritation with food. Perfect. And dysphagia as well.
Yes.
What about association with Plummer-Wilson syndrome?
We will see the dysphagia and the iron deficiency anemia, and moreover esophageal web. It's a triad.
Perfect. It's a triad. Okay. Zenker diverticulum.
That's a false diverticulum.
False? What do we mean by false diverticulum?
Relax.
It does not. It just involves only the mucosa. It does not involve the all the layers of the skin.
Perfect. So, what would be the presenting features? Dysphagia of obstruction and halitosis, bed birth, right? Due to buildup of the fluid. Okay. Esophageal varices, we discussed that, right? So, the next topic which we are going to discuss is achalasia. Who is going to be telling me achalasia? What is achalasia?
This is increase in the lower esophageal sorry, that's not me.
No, in the achalasia, what was there is inability, like the lower esophageal sphincter it cannot relax. Cannot relax. Yes.
Perfect. Perfect. It's basically damage of ganglion cells, and as a result of that, we cannot relax the lower esophageal sphincter. So on imaging with barium swallow, we are going to see a characteristic finding. What's that?
Bird's beak.
Bird beak
Bird's beak.
appearance.
Bird's beak.
Right? Okay, that's perfect. And which bug can cause it? Cause the damage of ganglion cell?
Trypanosoma cruzi.
Okay.
Chagas disease.
Chagas.
What are the clinical features which you are going to see on your UWord MCQ? Pertinent breath, bad breath, bird beak appearance, dysphagia for solid as well as liquid, because food content cannot move into your stomach, right? And the lower esophageal pressure is going to be raised. That is, on esophageal manometry, the pressure is going to be raised there due to inability to relax. Perfect. Okay, let's discuss GERD along with bad esophagus and along with adenocarcinoma. So let me just give you an overview. We know what is GERD whenever we have chronic reflux of gastric acid into the lower 1/3 of esophagus. What happens? We are going to see metaplasia there, right? So the metaplasia is going to result in transforming your cells from squamous into columnar. Once they are transformed into columnar, we call that buried esophagus. And if we have, by any chance, if we have cancers of those columnar cells, it would be adenocarcinoma. Is that clear?
Yes.
So can I say that adenocarcinoma can only be seen in distal 1/3?
Lower 1/3, yes.
Perfect.
Yes.
And for the gastroesophageal reflux disease, as we discussed, it can be confused with cardiac arrest or MI. It can also cause damage to enamel of your teeth and ulceration on strictures as well. Okay, so let's discuss esophageal carcinoma. So we know we have squamous cells there, so it can have squamous cell carcinoma. Either it can have adenocarcinoma in case of Barrett's esophagus as well. Right? So the upper 2/3 is going to have squamous cell carcinoma, and if we have adeno, so it must be present at the lower 1/3. That's an important point. Just keep that in mind. Okay, what are some of the causes? We discuss alcohol and tobacco. Why? Chronic irritant.
Chronic irritation.
Hot tea. Again, chronic irritation. Achalasia as well. Again, chronic irritation by the food particles. Esophageal web as well. Again, chronic irritation by food particles. Okay?
Yes.
Okay, perfect. So let's discuss something about stomach as well. Okay, so we are done with our esophagus. Okay, acute gastritis. We discuss what is acute gastritis. Is basically acidic damage of your stomach mucosa. We discuss in a big detail, right? Okay, so when the normal defense mechanisms are disrupted, then we are going to have this condition. What are the normal defense mechanisms? We already know that. Yes, what are they?
Bicarbonate, prostaglandin,
prostaglandins, your blood supply, and
mucus,
bicarbs, right? Mucus releasing biocarbs. Perfect. Okay. So if we have severe burns, an individual is going to have like hypotension, blood supply is going to be disrupted, and we can have ulcers, right? Or acute gastritis, not ulcer, right? Acidic damage. NSAID use, which are going to knock off your prostaglandin A2, right? What else? Heavy alcohol consumption, which is a direct irritant of your mucosa, right? Chemotherapy. Again, if you are knocking off the actively dividing cells that are mucosal cells, again, we can have damage of the stomach by these acids. We have chronic gastritis then. Chronic is a chronic inflammation. We basically have two variants or two types, right? H. pylori and autoimmune.
Autoimmune.
For autoimmune, we discussed that it's basically destruction of your gastric parietal cells. If you do not have gastric parietal cells, what will happen? We do not have intrinsic factor. It can lead to megaloblastic anemia, as we discussed. We'll be having type 4 hypersensitivity. Is basically due to type 4 hypersensitivity. T cells destroying your gastric parietal cells, giving you pernicious anemia as well. We discuss everything in big detail, right? Okay. So clinical features: atrophy, megaloblastic anemia. We have a lot of UWord MCQ on that. Okay. And as it is a chronic inflammation, so it can lead to metaplasia as well. That it can be transformed into intestinal metaplasia, right?
Yes.
Yes. Okay, perfect. And for the H. pylori itself can cause inflammation. It would be chronic. So again, it's like the second type of chronic gastritis, right? So it's basically urease positive. It can cause destruction there, and it can give us, like, again, intestinal metaplasia, gastric adenocarcinoma as well. Okay. So
Mark's lymphoma.
yes, Mark's lymphoma. Perfect.
Oh,
So the next topic which we are going to discuss is peptic ulcer disease, right? So who is going to be telling me peptic ulcer disease? I want you guys to participate as well. Just give me some break as well, okay? Yes, Dr. Daniela, please.
okay, I can go.
Yes, please.
So for peptic ulcer disease, basically we have two types. It's divided into two, like the gastric ulcer and the duodenal ulcer, correct?
Yes.
Now the main difference is the gastric ulcer, it's worse with food, but the duodenal ulcer is better with food. Because
Why?
when you're eating, right, your it does increase in your gastric acid, your HCl during the meal. So it worsens the gastric ulcer.
Okay. Perfect. Okay.
Then with duodenal is after digestion, so later on it's by the way, it's caused by H. pylori. Forgot.
Yes, H. pylori. Perfect. Okay, so duodenal by H. pylori. Okay. So, and in case of gastric ulcer, H. pylori along with NSAIDs use, right? So,
Yes,
as
NSAIDs
we
use.
know that with meals, the gastric ulcer is going to be, more painful. Epigastric pain is going to worsen. While if with meals, if it's improved, it means it's a duodenal ulcer because duodenum making more releasing more HCO3 from your pancreas and neutralizing, so the pain is going to relieve, right? Okay, what else? We discussed some of the benign ulcers and malignant ulcers. So can you just tell me some of the features of benign and malignant ulcers?
The benign ulcers?
Yes, benign and malignant peptic ulcers. Benign less than 3 centimeters, sharply demarcated. Malignant
And the
are
malignant
large,
have the
irregular.
larger in size and irregular margins will be irregular.
Yes, perfect. Irregular and heaped up margins, right?
Yeah.
Okay, perfect. So let's discuss our next pathology, that is gastric carcinoma, right? So gastric carcinoma is a malignant proliferation, right? Okay, so again, it's basically subdivided into intestinal and diffuse type. So, okay, Dr. Mariam is going to be telling us about intestinal type of gastric carcinoma. Yes, please.
Yes, the intestinal type is associated with H. pylori infection. Also, the nitrosamines, the dietary factors like smoked foods, and the
Autoimmune gastritis as well.
yes, and the autoimmune gastritis is also associated with this chronic because of the chronic gastritis. Chronic
Okay.
irritation leads to intestinal type, and the achlorhydria. So these are the risk factors of the intestinal type.
Perfect. So, and again, what would be the features? Again, there would be irregular ulcers with heaped up margins as well. Okay, in case of gastric carcinoma. Okay, for the diffuse type, we have special cells. Can you just name that?
Signet ring cells.
Okay, so what are signet ring cells?
These are the mucin filled, and the nuclei are displaced peripherally.
Yes.
Ring.
Okay. So mucin pushing nuclei towards periphery, they are signet. They are going to be present diffusely, and with presence of these cells diffusely, your stomach is going to respond in a way that is going to undergo desmoplasia. So what is desmoplasia?
It's thickened wall of the stomach.
Thickened wall.
Perfect. So it's basically thickening of stomach wall. That is also known as linitis plastica. Okay. Okay. So let's discuss if these tumors want to metastasize. So which lymph nodes would they love to go?
Supraclavicular,
Virchow nodes. Okay, perfect. So let's discuss about something about our small bowel, right? So we are done with stomach. So the first condition which we'll be discussing is Meckel's diverticulum, a very common and most very high yield. So who is going to be telling us about Meckel's diverticulum? Yes, guys, it's your revision. Please do participate.
Sir, it's the persistence of the Whitland duct.
Okay. Is it a true diverticulum or false?
It's a true diverticulum.
True.
True diverticulum, having all of 3 layers. Okay, so we have a rule of 2. Who is going to tell us rule of 2?
So it is 2 inches long and 2 feet from the ileocecal valve, and
Perfect.
the population.
2% and basically seen at 2 years of during the first 2 year of life. Perfect, right? Having heterotrophic gastric mucosa, giving you hematochezia, remember?
Yes, sir.
Can you just tell me what do we mean by melena and what do we mean by hematochezia?
Sir, melena basically means the bleeding is or the tear is at proximal to the ligament of the triads, and hematochezia is when the bleeding is occurring distal to the ligament of the triads.
Okay, which will be which bleeding would be more fresh?
The hematochezia
Perfect.
distal to the ligament of triads.
Okay, perfect. Can anyone just tell me something about volvulus? What is volvulus? We discuss it.
It's the torsional part of intestine around the point.
Okay, perfect. So if we are having twisting of the bowel along the mesentery, it's basically volvulus, right? And if we discuss at the apple-peel appearance, so you can just associate it with that. It results due to obstruction of the blood supply, and a distal segment of your necrotic bowel is going to revolve around or twist around your bowel. Okay, intussusception. Who is going to be telling me?
It is the telescoping of proximal bowel segment into the distal segment.
Why do we have that telescoping? We discussed the concept.
It's because of a different reason. Like for example, in children, we mostly have macula diverticulum. The pressure is increased, or there can be some kind of hematoma. And in adults, mostly there is an interluminal tumors.
Perfect. Okay. And what about some viral lymphoid hyperplasia can also do that. And the idea is that food would just drag the proximal portion of the movement of food would just drag the proximal portion into the distal. It would just telescope it, giving us intussusception, which increases the chances of getting ischemia of that respective portion of your bowel. Okay. Okay. So let's discuss our lactose intolerance, celiac disease, and we discussed it, right? So who's going to be telling us lactose intolerance in detail, right? The concept basically.
It's simply the deficiency of the lactase enzyme, because of which the lactose cannot be broken down to the glucose and the galactose, and mostly on the histopath will be totally normal, because there is nothing wrong with that, just the deficiency of the enzyme, and the person will be allergic to dairy products.
Okay, perfect. So basically we have lactase enzyme deficiency, which is basically present at the breast border. It can be congenital or acquired. Acquired is like the most common cause of that. So with consumption of dairy product, lactose cannot be like further metabolized, or it cannot be like absorbed. So it's basically a good osmotically active agent. It would just absorb all of the water, and the presenting features would be depending on that. That is, an individual will be having diarrhea after consuming milk products, right? And abdominal distension. Is that clear?
Yes, sir. Osmotic.
Okay, perfect. For the celiac disease, who is going to be telling us about celiac disease?
Celiac disease just is an autoimmune sensitivity to gluten. So
to gluten.
Yes, gluten.
Okay, specifically what is the pathogenic component of gluten?
Gliadin.
Okay. We have an enzyme. It can be against that enzyme as well. What's the function of that enzyme?
The transglutaminase. The transglutaminase. Tissue transglutaminase.
Yes.
That's the enzyme. The antibody against it is anti-tissue transglutaminase.
Perfect.
But also, we should note that celiac is also associated with the HLA-DQ2 and HLA-DQ8.
Yes, HLA-DQ2 and DQ8. Remember that. Okay?
And it will present with the dermatitis herpetiformis, which are the lesions seen.
Yes. Please just add on. Okay, what is dermatitis herpetiformis? Yes.
These are kind of like vesicular lesions which can be seen on the skin.
Extensor surfaces like the elbows and the knees.
Can I say that it's basically due to IgA depositing at the dermal papillae, giving us these? Perfect.
Yes.
Okay. So what would be the histopathological findings? Flattening of the villi, hyperplasia of the crypts, right? And intraepithelial lymphocytes, because it's basically lymphocytes which are T cells causing the damage. Okay. How do we how the symptoms are resolved? Just take gluten-free diet. Okay.
Yes, sir.
And in patients who are IgA deficient, you look for IgG.
Yes, those who are IgA deficient, we're going to look for IgG. Perfect. So let's discuss our next pathology, Whipple disease. Okay, so Whipple is a favorite disease of Dr. Abdul. So he is going to tell us about Whipple disease.
So this is basically called by infection by the Trophorma whippleyi. And it will simply present with foamy macrophages, which are periodic acid shift stain positive. And however, it can also have the extra symptoms, like it can also present with arthralgias or the cardiac joy symptoms, and some symptoms as well. And as related to the GIT, it will only be like diarrhea, abdominal pain, and weight loss.
Okay. So can I say that due to presence of these granuloma kinds of things, that is macrophages filled with T papillae, it would compress the lacteals, and as a result of that, what happens? The chylomicrons cannot be transferred into enterocyte, which is going to cause fat malabsorption and steatorrhea, along with ADEK deficiency.
Yes, sir.
Okay, perfect. Carcinoid tumor, a favorite pathology of
Daniela.
Daniela, okay.
Neuroendocrine tumor.
It's a
Okay.
neuroendocrine tumor, Muskan.
Yeah.
It's a neuroendocrine tumor which causes secretion of serotonin like leucine that causes what's it called? Serotonin syndromes,
Yeah.
flushing, diarrhea.
Okay. In which case do we see serotonin syndrome? If it's present within the liver, or whenever it's present within the small bowel?
The
Liver.
extra
In the
The
liver,
liver. It's present in the liver.
because bypass the
As to the
hepatic degradation.
Okay. So Dr. Mariam is going to tell us that in detail, okay?
So
Yes.
there are carcinoid tumors are basically they arise from the neuroendocrine cells. They are of different types, intestinal types as well as the extraintestinal types. Extraintestinal we see in the lungs and in the other places. And in the most common place is the small intestine and the appendix. And these tumors release the vasoactive substances. So these substances are get metabolized by the liver, and if the extraintestinal type, they can't get metabolized by the liver, so they can bypass the liver.
Which metabolize the serotonin? Can you just name the enzyme in the
This
liver? Which metabolize?
yes, the metabolized by the P450 cytochrome.
Monoamine oxidase converting it into 5-HIAA, right?
Yes, yes.
5-HIAA can be excreted in urine. But if we
In
have metastasis of carcinoid tumor into the liver, now we are skipping that part. We cannot metabolize it into 5-HIAA. So what happens is the serotonin is going to peak into systemic
Carcinoid syndrome. Systemic carcinoid syndrome, and in which the patient will present with flushing, diarrhea, such kind of symptoms.
Yes. Okay. Triggered by alcohol, emotional stress, which stimulates. Okay. So, okay. So we are left with some of the pathologies. So I think we should just, just continue tomorrow. What do you guys say?
Yes, please.
Yes, doctor, please.
Yes, because we don't want to, rush it.
Yes.
Okay. So tomorrow, then you guys should have your assessment, and please just now go and revise some of your UWorld MCQs for tomorrow's assessment. And then day after tomorrow, let's start our last main system, that is Repro, which like Dr. Muaz is going to take sessions on, right?
Yes, sir.
Okay. Is that okay?
Yes, sir.
Or shall we just
Yes, sir.
continue